who are unaware, this is an online community of practice where we come together and share knowledge and best practices around improving and implementing the national cancer control at various country levels in Africa. So we typically have discuss different issues that the community identifies as areas of need. And usually we have what we call a case presentation and a didactic, where we take a case scenario from at the country level, and then we now have expert speakers talk, and then everybody chimes in. So we usually like it to be as participatory as possible. And so before we go right into today's session, just to say that we'd like to ask if you're not speaking to, mute, but we would also like to have everybody's videos on to really improve engagement. Today's session is going to be very different, not a little bit, very different. And we're going to be talking about something that has created quite a buzz in Africa and indeed globally. We are going to digress away from the typical case and didactic, and we're going to have a panelist session of 4 great speakers, experts in their own right. And today we are going to be talking about the Lancet Commission on Cancer in Sub-Saharan Africa. The report that was launched in May, for those who are unaware, it was originally launched in May, and we've had another echo launch 2 weeks ago. So today we are going to be talking about that, and the broad objective of today's session is to have an overview of the 8 recommended actions from the Lancet Commission reports. And we're also going to be discussing the immediate next steps that the African Cancer Research and Control community can take to adopt these recommendations, with specific focus on designing healthcare systems that promote equity of access, increasing cure and improving care, and also investing in telehealth. So there are 8 recommendations, but we're essentially going to be focusing on these 3 today. But of course, all our speakers are welcome to talk and touch any other one as the case may, as they deem fit. So like I said, we have 4 great speakers today. We'll start off with Professor Will Ngwa, who was the lead commissioner for that report. And Professor Will is the founding director of the NIH-supported Global Health Catalyst Summit, which was launched at Harvard and has been in existence since 2015, and focuses on catalyzing high-impact collaborations between high-income countries and low-middle-income countries. He's a distinguished professor of public and global health and has numerous faculty appointments at Harvard, Johns Hopkins, and University of Massachusetts. He currently co-leads the Africa Oxford Hopkins Clinical Trials Network on Cancer. So there are so many other things we can say about him, but in the interest of time, we'll put out all the other information concerning Professor Will Ngwa on the chat so that you can look through and see how great and eminent our speakers are. We also have, I'm just going to read all our bios of all our different speakers, and then we'll call them up one after the other. We also have Dr. Miriam Mutebi, who is a consultant breast surgical oncologist, and she's an assistant professor in the Department of Surgery at the Aga Khan University in Nairobi. She's a clinical epidemiologist and health systems researcher with a focus on women's cancers. She's the president-elect of AORTIC, Africa Organization for Research and Training in Cancer. And she's also the president of the Kenya Society of Hematology and Oncology, otherwise known as KISHO, and she serves on the board of directors for the UICC. She also participated in 3 Lancet commissions for women and cancer, cancer in Sub-Saharan Africa, and also breast cancer. We also have Dr. Beatrice Waife, who is the CEO and founder of Breast Care International Peace and Love Hospitals based in Ghana, with 2 locations in Accra and Kumasi. She's a breast surgeon for the past 20 years and a consultant in breast cancer management. She serves on various, too many to mention, international and local boards and committees, and has been in advisory roles for the Medical Advisory Board for Ghana, Direct Relief USA. She's also sat on the board of the UN. Then next we have Dr. Kingsley Undo, who is a clinical assistant professor of global health at the University of Washington, and he's the founder and chief strategist of Huron AI, which is a digital health startup that is focused on bridging the gaps of cancer care and improving outcomes in substance. Even while based in the US, he also sits on the Ondo state government in Nigeria to help them with their cancer control. So without further ado, like I said, I did say that we have eminent speakers, panelists are experts in their own right. I'll call on Professor Will Ungwa, who will start off with presenting a broad overview of the Lancet report on cancer in Sub-Saharan Africa. Will?
Oh, thank you very much, Amaka. Hello, everyone. It's really wonderful to be able to present about the Lancet Commission on Sub-Saharan Africa and just kind of recognize, yes, we have really wonderful co-commissioners with us today and we'll be talking a little bit more detail with them as we go ahead. I wanted to say that during my presentation, I will just start by giving some background on the launch of this commission, and then I'm also going to talk about the calls to action, and then maybe my colleagues can dive into the more details of that. So I just want to start with this caption, which I think is really important to talk about, which is that we've seen too many reports, too many words, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in taking collective action to accelerate cancer control in Sub-Saharan Africa. Why this is really important is because, you know, there have been many reports about cancer in Africa, and I think that this commission just is not one that we just have to put on our shelves. The most important part of this will be the calls to action, you know, implementation, and it really has to be collective action. I would say that in terms of the backdrop for this commission, the statistics in Africa for cancer are really, I would say Africa is under assault because, you know, if you look at the projections, some of these were already known from the IARC reports, you know, but we actually see that these projections of about 1 million deaths per year could come earlier than 2040, and partly because we've seen what's happened with COVID-19, and the fact that we actually think that some of these estimates are underestimates. I would say the commission was created really to
Hello, Will?
Yeah.
Sorry, I think a number of participants are saying that they're unable to hear you. If you can increase your audio, that would be great.
Oh, okay. Is that better? Can you hear me?
Well, I can hear you, but
okay.
But the other participants, is this better?
Okay. Yeah, hopefully that they can hear me now. So yeah, the commission was created to really inquire into and analyze the state of cancer in Sub-Saharan Africa, and then to recommend key actions, you know, mostly hopefully that this can be implemented by governments, which are really part of the healthcare system. They really drive some of the healthcare system in Sub-Saharan Africa. I would say that over 50% of the commissioners were Africa-based, and over 50% were women. And obviously, one of the champions for that was the co-commission lead, Dr. Beatrice, who is with us today. And I would say that we actually walked throughout COVID-19. So the commission was actually launched during the AODIC conference in Mozambique. And then in 2020, we had, just when we were about to start, early January, February 2020, then COVID-19 hit. And so right away, you know, we, the commissioners, were very challenged on how to work. And so throughout throughout the work, the work we actually worked through during the COVID-19 pandemic. And I really want to comment, just there are 4 of us who are here today, but there are actually 54 commissioners, one of the probably the largest commission that the Lancet oncology has had. And each one of them worked really, really hard. So I just want to say that, you know, this is a really tremendous piece of work and effort. Before I talk about the calls to action, I want to mention that there were a number of key surprises for me. And I think, you know, we all, when we read such a report, we wonder, okay, what is new in that, you know? And I think for me, one of the biggest surprises was that, yes, I knew cancer was a silent killer in Africa, but I think, you know, the magnitude of the cancer problem, you know, the commission really shows from the commission analysis. I saw that this problem is actually really enormous and something that we really have to act quickly, otherwise it's going to worsen rapidly. One of the key things that came out for me, and that's why, again, some of the important work on education and awareness that's being done around prevention. You know, there were some really good examples highlighted in the commission about some things that are happening in Africa. It's not all bad news. And one of those models was actually that of Dr. Beatrice. And I think that it is really important because out of the 2,000 languages in Africa, approximately estimated, you know, there are many languages, dialects that still don't have a word for cancer. And that's a huge issue. It just kind of highlights the fact that we have this problem. If you don't have a word for cancer, you can even begin to address it. So that tells us that we really need a lot of education and awareness around this. I shared 2 more surprises. And I think one was really the fact that by 2050, almost 50% of the global cancer burden in children will be in Africa if we don't act now, you know. And so, you know, we have really seen that the burden, you know, in the United States, you know, 4 out of 5 people, kids will diagnosed will be cured, you know, will survive. That's flipped in Africa, essentially. And I think that that's something that really breaks our heart to see that we have to do something for our children. The third one was really the treatment abandonment. I really think the rates here were tremendously high. To think about 54%, 46% in Zambia, you know, and I think that is going forward something that we really need to address. There are potential reasons for that needs to be need to be analyzed, but it is one of the reasons why, you know, the cancer death rates are so high. You know, the incidence to death ratio, you know, the death rate is really, really high. So I think that this is one of the surprises that I think we need to also look into addressing. So for the next couple of minutes, I just want to mention the calls to action, and I think my colleagues will have the time to dive a little bit deeper in those ones. The first one is really the precision cancer control. You know, being able to develop national cancer control plans. That's really, really important to decide on sustainable financing for that and implementation. The next one was improving data acquisition and cancer registration. So I think this is really important because, like we said, in this commission, we even think that some of the estimates are really underestimates. And so without data, we really have no way to, you know, develop concrete actions to address this. And then designing healthcare systems that promote equity of access. This was really important work done by Kingsley and a number of people in sections, former Minister of Health in Nigeria. I think this is really important, you know, to have universal health coverage. Some countries in Africa are moving towards this, and these are some of the bright spots that we really need to emulate and adapt across Africa. Action 4 was increasing cure and improving, making sure that we improve cancer care. And I think that most of us on this call today probably identify with this if you are involved in cancer treatment. So there's a lot of work that needs to be done here, piloting cancer screening early. Miriam and his group, she was one like that. They did a fantastic job in this particular call to action. And I think that is something that we really have to work collectively on as well. 5 is effective palliation. While we're trying to do the treatments and early prevention, In the meantime, we know that the majority of African patients, 70 to 80%, present with advanced disease, which means that palliative care is critical. And so this is one thing that we really have to urgently. So we actually put a time frame of 1 to 3 years here because we really have to address palliative care. Then number 6, obviously the workforce is fantastic. It's really critical to strengthen the healthcare system. And so, there's a number of bright spots here. Also, some countries like Tanzania, there are some places that are really developing this in South Africa. And those are examples that we really have to also emulate. And then number 7 is innovation and research. This is really important. We did notice from this Lancet Commission that African governments had failed in their commitments to invest part of their budgets into research. And I think that this is a time where we can really work together again and get government leaders to reinvest in this and make sure that, as COVID-19 has taught us, Africa can really drive its own innovation and develop its own vaccines. Not only that, but then addressing the cancer crisis. And then 8, as Dr. Amaka mentioned at the beginning, one of the key things is really where we think Africa can leapfrog into a new era. It's really investing in telehealth and working on things like digital health solutions and artificial intelligence. Some of the things that countries like Europe and the United States have gone through, we could probably leapfrog that, literally into an era where, we can tremendously increase access to care as COVID-19 taught us. Yeah, so I just want to end there and say that, this calls to action really need collective action. We just had a number of launches. So the first launch in Ghana, and then currently we did 2 weeks ago, like Amaka mentioned, in the United States. And so now we are going to be looking at other places to launch as well, but in particularly engaging the African governments and the African Union. Just yesterday, the White House did announce the US-Africa Summit with presidents coming up at the end of this year in December. So it's going to be really important. We're already working with the White House to make sure that cancer is front and center in that discussion, that Africa can really invest into that. All right, I'm going to stop there and hand over to let my other colleagues also talk.
Thank you, Keith, Will, for the overview and telling us, sharing with us the recommendations from the report that was done. We want to thank the commissioners, like you said, for working even throughout the COVID. If there's one thing we learned during the COVID is, we had always known that the health systems in Africa had not been, well, suboptimal and very weak, but that really came up very clearly during the COVID-19. So we decided as a steering committee to touch on 3 different aspects because we know that the health systems in Africa are weak and we know that there's a recommendation to strengthen it. So at this point, I'd like to call on Dr. Beatrice Waife to talk a little bit on what, the commission was thinking of, when they went ahead to talk about the recommendation on developing and designing healthcare systems to strengthen cancer care in Africa. Dr. Beatrice. You're muted.
I'm muted.
Yes,
hello.
Fine now. We
Good
can hear you now.
afternoon, good evening. And hi to all my commissioners, members of the commissioners, and lead commissioner, Professor Ngwa, Professor Kerr, who is not with us here today, and hi to all the other commissioners, without whom we couldn't have put out this great work for Africa, especially Sub-Saharan Africa. In fact, before we even start deliberating, there are 2 very important things we need to touch on in Africa. When we talk about accessibility and when we talk about affordability, sometimes we can have access to care, but may not be affordable. So if we have all the equipment, if we have all the hospitals and the people are not able to afford them, Have we done enough? There are certain things that we can do for ourselves that individual organizations, NGOs, civil society organizations can do in cancer care, because oncology is not like any other discipline. It's different. And so the way we do our things must also be different. How come we don't have registries at all? Data and data management, data collection. How can we make our case without having the necessary information, which we will carry to our policymakers to get the change that we aspire? So we need to start from our data collection and data management, something that is normally not on individual basis. We need to get our governments involved in this aspect, in data management, data collection, and also bearing in mind that normally the people that we plan to help are those located in the communities and not in the cities. In most African countries, Sub-Saharan African countries, treatment centers are in the cities. So people will have to travel for hours before getting to a treatment center. And how can they get there when they don't have any support? We should come together to talk about the support that we can look for these people, even for traveling purposes, so that they can travel to these treatment centers. Most of our cases are late-stage cases. And so most of our attention should be geared towards early detection measures. If we are able to detect our cancers early, we will be able to get treatment for them and get enough survivors who in turn help us to talk about the various cancers. Because if you have a lot of breast cancer survivors, you have a lot of cervical cancer survivors, prostate cancer survivors who come out and talk about their conditions and their disease and the fact that they've come out of the disease, as healthy people. It will encourage other newly diagnosed people or those who have even found something and they are scared to go to the hospitals. So we need to, as much as we need to talk to our governments to put in measures, like to put up the infrastructure that we need to also talk about training of the healthcare professionals, the frontline workers. We have a lot of breast cancer, a lot of nurses, community-based nurses, and we can retrain these nurses to help us in clinical screening. And like the example Professor Will was mentioning that in Ghana we've done, it's about what Breast Care International has been doing, which we think that most African countries can emulate, to train community-based nurses, to train nurses who can actually identify early stage disease and to assist and navigate these newly diagnosed people to treatment centers. The centers which are based in the communities and the small cities should be particularly trained, the nurses and the workers there, because they are normally the front line, the people who are seen first. And so if they are able to identify the disease early, that's when they can also refer them and have a good referral systems to get these patients into the treatment centers. In fact, I talked about affordability. And if you refer a patient and the patient is not able to afford the treatment, then you might as well leave him or her in her village. Because if the person goes to the center is not able to afford the treatment, then we've rather, made an already bad situation worse. The person is worried, and then we bring these financial worries as well. So we should look at ways that we can help our people to get the help they need, whether it's opening some funding opportunities for them. Most African countries do not have social support systems. So our patients do not have anywhere to run to for help. We should think about this, whether it's through the civil society organizations or NGOs, or even some governments can come on board and assist people who are diagnosed with the disease early before the diagnosis metastasizes. Because we know very well that when the disease spreads, then it becomes very expensive to treat them. We should also try to send centers for screening to these areas. And that is what we've seen, that it yields a lot of results. So we send the nurses or the healthcare professionals who can screen for these cancers. So whether it's breast cancer, it's cervical cancer, it's prostate cancer, we have people who have been trained to go and pitch their tents near the communities where people can easily walk to for the screening. Because a lot of people are walking without knowing that they have one disease or the other. So if we are able to screen them early, and we know that most cancers do not start with pain, and our people will always wait for pain before going to the hospital. So why can't we go to them and screen them to find out early stage disease? If it's cervical cancer, the patient can receive the see and treat kind of engagements, and the loop is done to preserve the service for her to be able to have children. If it's breast cancer, the patient can then go further for further diagnostic measures, including the core biopsy to identify what lump she has or whatever disease the person may be having. One thing we shouldn't also forget is about accountability. Accountability is a key topic when it comes to equity of access to healthcare. And we should try and ensure that our healthcare professionals, especially those in the communities, in the rural regions, are held to a certain standard. We cannot use the reason, the excuse that we have a lot of cases, a lot of patients to see, so we don't have time to spend on somebody who has walked in for screening. We should have time for these people. And then we should also make sure that the healthcare professionals who are in these communities are adequately staffed and equipped. If they are in the rural communities and they are not even able to get the gloves that they need to work with and things that they should be provided with, then we won't be expecting any positive results from whatever we do. This Lancet Commission's report must serve as a catalyst to help us to move from where we are to the next level. We cannot continue to do things the way we've been doing. We must try to change things. And we should always bear in mind that medicine should be about saving lives and not just making money. Let us see how we can help our people. And those who are poor should not die because they are poor. They should have some support to help them to live well, despite the fact that they are
so much.
Thank you too.
Thank you. Thank you so much. Very well said. Indeed, that is definitely from the CEO of the breast cancer health systems hospitals in Ghana. I mean, so many things you've talked about here, next steps that we can begin to immediately think about to improve and design, strengthen healthcare systems, talking about task shifting, improving access to community, and providing linkages such that when these patients are picked up at the community, they are not lost along the loop. Also talking about the need to promote accountability and equity. And we do know that we're understaffed, so we should also be thinking about opportunities to optimize the staff and maximize what we have in order to be able to close the care gap. Thank you so much, Dr. Beatrice, for all those comments and next steps that we should be looking at to strengthen the health systems. Okay, so with that said, I think I'll go over to Dr. Miriam Mutebi, a breast surgeon. What do you think are the easy, quick wins that will help us to improve and increase cure and care on the African continent? Miriam?
Thank you so much, Dr. Marka, and to our lead commissioners, Dr. Wiafi and Prof. Ngwa, for that excellent introduction and really sort of trying to highlight the key findings. When we sort of look at, the concept of improving cure and overall survival, we kind of see we do ultimately end up sort of talking about all the 8 calls because they ultimately do translate into improving cure. I think most of us, we've already discussed the picture that occurs, and we know that quite a number of our patients not only are diagnosed at advanced stages of their disease, but frequently do not complete their care. And we've, both the first 2 speakers have tried to allude to the sort of deeper reasons behind that. And we see a constellation of factors, the biggest one being the financial factors, the fact that patients have to pay out of pocket, resulting in catastrophic health expenditure. This is further compounded by health systems, where we know that healthcare workers may sometimes act as barriers to care, where we do know at least on average in Sub-Saharan Africa, a patient is going to see at least within on average 4 to 6 healthcare providers before definitive diagnosis of their cancer is made, really speaking to the need to educate our healthcare providers. And then looking at the further broad category, which the 2 speakers sort of talked about as well, is really looking at the social cultural barriers that exist to care, including stigma, collectivism, where our strengths, our strength of community is our strength as Africans, but it's also it also is a double-edged sword, for instance, where patients cannot actually have autonomy or agency over their decision making. And so we, for instance, have women sometimes are not necessarily being the primary determinants of their health-seeking behavior. And certainly in breast, you have the community, coming to say, we have decided the patient will have a mastectomy versus a breast conservation. And so those are the nuances that we do need to look at. But I think one of the big things that we reflected on in the commission is really the concept of value-based care. And it's looking at how do you provide quality services at a cost-effective rate that's not going to break the bank. Dr. Wiafe really talked eloquently about accountability. And I think we do need to think about how that accountability starts all the way from the top, where we do need to look at deliberate investment in healthcare services by countries. We are still lagging behind in terms of our GDP and the percentage that's actually invested in providing health services. We do know that centers that do provide universal, or countries that have universal healthcare coverage, or at least models of the same, do actually do better in terms of improving overall patient outcomes. I mean, we've had the National Hospital Insurance Fund in Kenya that was introduced maybe a couple of years ago, but really sort of started supporting healthcare, different aspects of the care continuum, whether it was chemotherapy, radiotherapy, surgery, but we're certainly seeing more patients actually completing their care. I would say about 10 years ago, it was pretty standard to have a patient, have their first cycle of chemo and then disappear for 6 months and then come back, and they're really excited because, they're like, we've raised enough money for the next course, and which is really heartbreaking. So those are the kind of narratives that we really need to be thinking about shifting. And then once we think about, yes, we have deliberate investment, but again, the backbone of any system delivery is workforce. That cannot be emphasized enough. We do need, yes, we're understaffed, but we do need to think about how do we improve training and access and the skill sets. And even thinking about training is a two-edged, is a double sort of a dichotomy. We do need to think about, one, how do we increase the workforce? But it's not just a numbers game. What is the quality, what is the value of the services they're providing, but also what is the quality of training? Because I think one of the big challenges that we're having in many parts of Africa is everyone sort of setting up a little kiosk and saying oncologist and doing all sorts of things. And so looking at, even then, how do you homogenize training across the continent or the region? And so there needs to be deliberate investment in one. We talked about, coming up, making use of the screening guidelines and the harmonized guidelines. And I think many people on the call have been part of that process. But how do we then, percolate that down to, is everybody practicing evidence care? Are we giving the best for our patients? And then looking at, yes, we're increasing the specialized workforce, but how do we homogenize the existing workforce? For instance, the majority of cancer surgeries in Africa are done by general surgeons. How do we ensure the skill set that if I'm doing a modified radical mastectomy in Ghana or a modified radical mastectomy in Tanzania or whatever, we're still getting the same quality of pathology services? So those are some of the considerations that one would need to have in terms of the workforce. Again, in terms of the actual access to medications and things, we do need to look at pooled procurement. We do know that countries in Sub-Saharan Africa are paying 3 to 4 times more, an equivalent for a cost of a drug that they would in an equivalent low and middle income country. So it's looking at how do we take advantage of the opportunities that exist around pooled procurement. There have been several initiatives that exist. How do we tap into those and leverage our ability to acquire drugs at a cheaper cost for patients? And again, looking at sort of circling back to, if the majority of our patients are getting diagnosed with advanced disease, it behooves us to think about how do we improve access to palliation and supportive care services. And I think some of the under-tapped areas that we don't think about is really the supportive care, because we sort of tend to equate palliation to end of life, whereas we're saying palliative and supportive services start from the time of diagnosis. Where is the access to psychosocial services? Where is the access to consumables like stoma bags or prosthesis? So those are part of the things and opportunities that we do need to look and think about critically in our approaches to how we can help to improve cure and overall survival for our patients on the continent. Thanks.
Thank you so much, Miriam. I certainly hear you and I agree with you. Promoting and prioritizing value-based care is definitely something that we should be big on the continent, considering that resources are lean. You also talked about the need for improving workforce. We should be able to think about innovative ways to do that now. We've seen that during the COVID era that there were lots of innovative solutions that came out to be able to, for instance, the vaccine, we were able to get the vaccine out earlier than it normally would have. So I think in also developing the workforce, we should be able to think about innovative ways to do that in a timely manner and really trying to close that care gap. Implementation that you said of evidence-based care, I think is another thing that we should be prioritizing on the continent as well. So many things that you mentioned that we can begin to look at, I think it would be important to really sit back and think about all of this in a systems-based approach so as to know which to prioritize. And then with thinking about all of this, I'm moving on to Kingsley now. Is there a role for telehealth, artificial intelligence in any of these areas that Miriam talked about in terms of promoting diagnosis, entrenching value-based care? What do you think are the opportunities? I know that you're really big on telehealth and AI, Kingsley.
Yeah, thank you so much, Amaka, and hello everyone on the call. I know we're fast spent our time, so I'm going to zip through and hopefully we can have some time for discussions. So basically, telehealth is essentially just the use of mobile devices for healthcare provision. And there's growing evidence that, telehealth can help to reduce the inequities we see in cancer care because we've seen it in other disciplines. Essentially, the reason why we recommended telehealth in the commission is that it helps to mitigate, there's a potential to mitigate the paucity of, the health workforce. It can help to improve diagnostic efficiency and accuracy with the growing body of work in precision medicine. It's very important that the African cancer data gap can be closed using telemedicine. And we can definitely help to promote clinical trials and drug discovery using digitizing the system. We know that there's one oncologist to 3,000 cancer patients in Sub-Saharan Africa. When you compare that to high-income countries, you see that in tandem with all the efforts that are going on in capacity building and training, we can use telehealth and artificial intelligence as a way to augment some of these efforts. We have huge data redundancy in Africa, and you know that if all this was digitized or if it was in a digitized form, there are lots of insights we can get on treatments, on the cause of cancer, prognosis in people of African descent, having the opportunities to do personalized prevention strategies. So this can be harnessed if we digitize the system rather than just being redundant and a lot of knowledge being wasted. You can see that this image shows the need why things like AI research and telehealth needs to be done on the continent. On the left, you can see that is the same lesion, Kaposi sarcoma, which is skin cancer that is usually seen in HIV patients. But when you train with just Caucasian data or majority Caucasian data, you tend to have bias. And so that is why it's very important to invest in AI research, in digital health on the continent, so that these disparities and the health equity we're trying to build in 10 years' time would not be saying, oh, we're still having these huge disparities. Now is the time to start investing in these technologies, because then we can have the data that will be used to drive prediction, drive decisions. This is a study that was done to show that, and it was basically kind of monitoring compliance for breast cancer treatment. And in this study, the PI came to this conclusion that African Americans were markedly more likely to have reductions in dosing of an important part of chemotherapy, which is the taxanes, because their side effects and these reductions in doses led to a less favorable outcome for breast cancer from a breast cancer standpoint. So this just shows that if we don't do this, carry out like trials in people of African descent or in Africa, there are certain side effects that we may not know the frequency of, because as you can see in this study, the African American women took the drugs less. They were less compliant because they had more frequency for the major side effects that the drug had. Obviously, there are challenges that anytime we think about telehealth, people just think about the challenges. There's a low rate of smartphone penetration. Very few countries have data governance and ownership. there are no regulatory frameworks, so there are few regulatory frameworks that would help to approve some of these digital products. Of course, there's high cost of internet and data and insufficient electricity, especially in rural areas. However, we have areas of investments that I think we can move the needle. First, we have to invest in data infrastructure and capacity building in data science. The NIH is actually even championing that. There was a huge grant given to several centers, I think it was last year, to build AI and data science infrastructure and capacity. We need to have more validation studies of existing AI models that have been developed in the West, because the clinical setting and the data that was used to develop these models are different and may not be transferable to Sub-Saharan African settings. So these validation studies need to be invested in. There has to be, we need to expand more local and regional international tumor boards. There are lots of them going on between the global north and the global south. We need to expand them. We need to even have more even within Africa. And then we need to invest on the regulatory frameworks that would help, that would support the approval processes and to ensure that patients are safe. And in investing in telehealth, the World Health Organization already have a well-documented global strategy on implementation of digital health, especially in low and middle income countries, and that should be done in this context. Sorry, I'm really fast because I know we're running out of time, but hopefully we'll have some time for discussions. Thank you so much.
Thank you, Kingsley, for going through those slides very quickly. But I think, lots of important things that were said. Even as we look to AI as the opportunity, we should also be mindful of the various challenges that are there. So I'll open it up for questions now and discussions. A lot of things have been said, with the last speaker talking about the need for validation and really adapting some of these technologies to our local setting. I think there's a real opportunity there. And just to mention that for those that are really interested in, pushing the needle further for data science, there's still another NIH grant that is out and will be due for submission in November. So again, this is another opportunity for partnership and collaboration for us to really move the needle forward for data science on the continent. Are there questions and comments from the audience? There's a lot that has been said. We're really trying to digest and integrate it. Indeed. Okay. Yes, Miriam, go ahead then.
Maybe to just tag on to what Kingsley said in his great presentation, is really one of the key areas is really we need to think about is really promoting the multidisciplinary approach to care. Because I think for the longest time, you kind of got the treatment depending on who you saw first. If you saw a surgeon, you'd blink twice and be in OR. Or if you saw the oncologist, sometimes you may start with chemotherapy. So really trying to strengthen that sort of collaborative approach to care, and keeping in mind that supportive care, nursing as well, and diagnostic are all really a key component of that care continuum. So that would be one of my comments. And then really also sort of circling back to one of the recommendations of, yes, we would love to have innovations and AI, but really saying they're not a substitute for dysfunctional systems. So let's strengthen the systems and integrate the AI to help actually support our processes, as it were. Thanks.
Yes, very well said, Miriam. And indeed, I think most countries are pushing forward the multidisciplinary team approach. I think one way to really enforce it will require lots of policies and government backing to ensure that. Emily, please go ahead. Emily, you have your hand raised. Would you like to ask a question, contribute?
I'm sorry, that was important.
Sorry? Oh, okay. I guess that was an error.
So before Emily steps in, I just wanted to sort of tag on to what Miriam said. Absolutely, I think we have to build this structure in tandem with all the other efforts that are going on in just healthcare system strengthening. Personally, I believe that it would definitely kind of push the needle and accelerate all the other efforts that are going on. It's definitely not a magic bullet, because obviously the patient needs treatment. There needs to be coverage, insurance coverage to increase access, and all these other pieces that needs to be there. So we definitely need to do all this in tandem to push the needle forward.
Yes, and then Salome made a comment in the chat talking about pooling procurement. Would you like to unmute to talk a little bit about that, Salome?
Thank you very much indeed. So yes, pool procurement is something that we have been putting forward more and more for cancer medicine specifically. As we know, I mean, cancer medicines are extremely costly medicines and not necessarily affordable. And we also have the issue with regards to essential medicines list. So on the one hand, we have got essential medicines lists, and not all the medicines are always available. So that in itself may be a problem. And then we've got high cost medicines that will in fact never be available if we don't start looking at the whole concept of pooled procurement. So it is something that we need to start looking at in terms of how do we do that? How do we start looking and bringing all the role players around the table when we want to implement something like that across borders? Because it's certainly not something that South Africa could do on its own. It really is something that we need to look at from a regional perspective. How do we actually engage with that? We now have an African Medicines Agency, so that could also be something of a role that they could take on. So there are definitely some issues, I think, that we really have to look at in a more collective and collaborative way in the future. Thank you.
Okay, I was going to send it to Miriam, but she also had a hand up, so go ahead.
Oh, thanks. No, I was going to say Salome's just pretty much hit the nail on the head in terms of really looking at how can we improve access. And there are several ongoing initiatives. We know the Clinton Health Access Initiative, for instance, the BVGH, BioVentures for Global Health. There's an international agency, African Agency for Acquisitions. So there are all these different players, but perhaps seeing how maybe we could move these beyond the regional or individual hubs to how we homogenize them. Again, Salome touched on a key aspect around essential medicines lists, which we realize sometimes go hand in hand with actually the national cancer control programs, because quite a number of countries don't actually have an essential medicines list. But the other issue is in terms of sort of taking the WHO list blindly, I think we really need to think critically about using clinical measures like the ESMO magnitude of benefit scales to really prioritize. We have, X number, we have about 100 medicines or 500, but what are the drugs that we actually need for our populations based on the disease burden and the need? And so looking at, yes, these are the drugs that are available, but what are the needs, and does it make sense? And are we paying, maybe X number of dollars for a drug that's only going to have a really, really small clinical benefit, as opposed to investing in, I would say, workhorse drugs that are actually able to provide and get us to better cure for more patients. Thank you.
Thank you, Miriam. I completely agree with you that pool procurement is the way to go. I know that for us in Nigeria, that has really helped. Pulling all those drugs and requirements together has helped in really taking down the cost of the drugs. And it has helped to improve access to drugs for children as well. But I think that right now, I think we are in collaboration with Nigeria and a few countries from East Africa through the Cancer Health Access Initiative that you're talking about. But perhaps we need to think about expanding it across board to maybe several other countries. This will really help to really bring down the price. I see two more hands. If we can just take one minute, short comments, because we're really almost at the top of the hour. So I will go first to Dr. Beatrice Adai and then to Bender. But I'd ask if you can really keep your comments really short because we're almost out of time. Thank you.
Thank you so much. So I wanted to touch on telemedicine and telehealth. We have a lot of our diaspora outside, and so let's tap into their ideas and the things that they are doing. So we can have virtual tumor boards involving these, our compatriots who are outside, and so that we bring ideas together and then use it for the continent. We should also not try to reinvent the wheel. What other countries have done and is beneficial, let's look up to them. And the book, the Lancet report, is ready with a lot of examples. So let's use it as a catalyst and let's leapfrog. Thank you so much.
Thank you, Dr. Beatrice. We need to adapt and ensure that these solutions that are generated outside are socio-culturally acceptable. Brenda?
Okay, thank you so much for the presentation. And I'll reference the point where, of the 8 action points that were pointed out by Professor Moore, I noticed that one of the critical pieces that I had hoped would also be highlighted would be how we are cascading the knowledge of all these interventions back to the community, because ultimately when you improve the healthcare system and we improve access to care and access to commodities, and at the same time, we still keep saying patients are presenting late in Africa, there could be a mismatch between the information that's available to the patient on where they can be able to access this information. And by that then, I would ask of the commissioners, how do we ensure that advocacy activities, community mobilization, education are also included in funding mechanisms, so that we don't find that the system is improving, but the patient who is supposed to be served by that system is not getting access to that information.
Thank you, Brenda. Will, you want to make a quick reply?
Yeah, just a quick reply. That's a really wonderful, question or feedback from the commission report. I think what you're really pointing to is the idea of implementation research that needs to go into this as well. There are a lot of really, we talk about, in the United States, the cancer moonshot, but, in terms of thinking about quick wins, the ground shot for Africa, there are many things that we really know work that we just need to kind of adapt. And the question is, some of those things are not working or maybe not being adopted in Africa. Brenda's point is really, why are these things not being adopted and why are they not working? I think that goes to the reason why there's increased funding. I think NIH also put some funding out now on implementation research as well. And I think that's something that we really need to prioritize as well as we look at how to implement these commission reports.
Okay, thank you so much to all our commissioners and all our speakers. We are really out of time now. We really we thank you everybody for their participation. And if you do want us to continue having these conversations, please let us know. And I'm hoping that we can pull the commissioners back later on for further engagement. But just before I hand over to our hub and to Mishka, I just want to say that, like Will said, implementation science is the way to go. There is an implementation science special interest group at IOTIC. If you are interested in furthering your knowledge or participating in implementation science research and even the practice on the continent, please reach out and we'll be happy to have you join us in the implementation science special interest group. So at this point, I'll hand it over to Mishka and to Charles from the Kenku Hub as we round up for today. Thank you so much to all our commissioners. Thank you.
Thank you, Amaka, and thank you so much, yes, very much for your presentations today. And that invitation definitely stands. We would welcome the opportunity for even a series of discussions around implementation of the commission recommendations. So thank you again for joining today. I'll now turn over to Charles to get us excited for the next series of sessions in August. Over to you, Charles.
So thank you very much, Mishka, and thank you, Amaka, and indeed thanks to everyone else for joining us today, and to our wonderful team of panelists from Lancet Oncology Commission. So we are going to be sharing the recording for this session on Basecamp for our reference. and we can also continue with our discussions over there. So we are almost coming to the end of our Africa Cancer Echo year. And our next two sessions are going to be focusing on strengthening pediatric palliative care in the African region. So our next session will be held on August 4th, same time. We are going to be sharing the agenda in the coming week, so look out for that. And the other session will be 4 weeks from now, again, focusing on pediatric palliative care services in the African region. So we hope that you are going to join us for those two sessions. Otherwise, thank you very much for joining us today, and have a good time, everyone. Thank you.
Thank you, everybody. Bye. Thank you for joining. Thank you, Beatrice. Thank you, Kings.